So let us talk about clinical approach to the disorders of the respiratory system. So let us talk about the overview of respiratory system first of all. The respiratory system can be affected by a various number of etiologies, which can include vascular, can include infective causes, autoimmune and allergic causes or atopic causes, neoplastic disorders, genetic or congenital disorders, metabolic and some toxins which include smoke, dust, fumes, or asbestos particles, silica particles, etc. due to occupational exposure, and traumatic is a rare cause. All of these etiologies can affect different anatomical parts of the respiratory system and can result in a number of disorders as follows. It can include airway disorders like asthma, COPD, or bronchiectasis. Asthma is typically or most commonly is an allergen-induced disorder. COPD, a chronic obstructive pulmonary disease, and bronchiectasis. The parenchymal disorders include pneumonia, interstitial lung diseases or ILD, sarcoidosis, and lung malignancies, which can be primary lung malignancies or metastasis. And pleural disorders, which can include pleural effusion. Now, pleural effusion means there's collection of fluid within the pleural space. It can be a hemothorax, in which case there is collection of blood within the pleural cavity, or it can be an empyema, in which there is a pus collection within the pleural space. It can be a case of a pneumothorax, where there is collection of air within the pleural cavity, or even a pleural malignancy or mesothelioma. Pulmonary vessels can be affected, as in pulmonary embolism. Now let us talk about symptomatology of the respiratory system disorders. There are certain cardinal symptoms of the respiratory system and etiology-specific symptoms. The cardinal symptoms of respiratory system disorders include breathlessness or shortness of breath or dyspnea. It can include cough and sputum production, chest pain, wheeze and stridor, and there are other etiology-specific manifestations which include fever, night sweats, weight loss, and hemoptysis. Now, assessing the shortness of breath or breathlessness or dyspnea. There are two objectives. One, to differentiate between the cardiovascular and respiratory origin of breathlessness, and two, to locate the underlying cause. Now, breathlessness, is it cardiological or is it respiratory? Cardiological cause of breathlessness is aggravated on exercise. It is aggravated on lying down and relieved on sitting up, a phenomenon called as orthopnea. It is associated with anginal chest pain, palpitations, and bipedal edema. Anginal chest pain is typically described as a retrosternal, dull, heaving, constricting pain that radiates towards the jaw, neck, inner aspect of the arms and forearms, and sometimes to the epigastrium. It is aggravated on exercise and is relieved by taking rest as well as taking nitrates. On auscultation of the chest, there are inspiratory crepitations and pro-BNP levels are elevated or the test is positive. Risk factors in cardiological breathlessness includes elderly male, obesity, diabetes, hypertension, smoking, and an underlying history of ischemic heart disease. On the other hand, respiratory cause of breathlessness has poor or episodic relation with exercise. Orthopnea is absent. It is associated with cough, fever, hemoptysis, and sputum production. On auscultation of the chest, there is expiratory wheeze. The pro-BNP test is negative, and the risk factors include smoking and autoimmune diseases. Once we have established that the breathlessness is due to a respiratory cause, we need to try to point towards the underlying cause behind breathlessness. So how to assess the underlying cause? We need to ask about the onset. Sudden onset breathlessness can be due to pneumothorax, pulmonary embolism, or acute exacerbation of obstructive airway disorders or AEOAD. Obstructive airway disorders include both asthma as well as COPD. Gradual or insidious onset of breathlessness can be due to a pleural effusion, interstitial lung disease, or neoplasias. Now, daily and diurnal variation is also to be asked for. Is the breathing normal on some days? If the breathing is normal on some days as stated by the patient, that is, the patient experiences no breathing difficulty on some days, it is suggestive of an asthma. Nocturnal worsening of breathlessness is also suggestive of asthma. However, if daily and diurnal variations in breathlessness is absent, it is suggestive of COPD. The relation with exercise is to be asked for. As such, respiratory cause of breathlessness has a poor correlation with exercise. However, COPD patients have a decreased exercise capacity, and asthma attacks may be triggered by exercise. Now, based on the degree of reduced exercise tolerance that is caused by a COPD, the dyspnea is graded on a scale called as MMRC scale, which is stated in the last slide of this presentation. Now, assessing cough. The objectives include 1. Differentiating between the respiratory and the non-respiratory cause of cough. And 2. If the cough is due to respiratory cause, then what is the underlying cause? Cough. What is the cause? We need to ask about the onset, duration, and progression. Now, duration of cough is very important. Any cough less than 8 weeks is considered as an acute cough if it is less than 2 weeks, and if 2 to 8 weeks, it is considered as a subacute cough. Such a cough is usually due to an underlying infection, the most common of these being a viral upper respiratory tract infection. Such cases are usually self-limiting and may sometimes require the administration of antibiotics. Any cough more than 8 weeks requires a detailed evaluation to rule out the non-respiratory causes like reflux of acid, as in gastroesophageal reflux disease (GERD), and is usually due to more serious respiratory causes like a lung cancer, obstructive airway disease or OAD, bronchiectasis, or interstitial lung diseases. Now, aggravating and relieving factors are to be asked for, especially inquire about exposure to dust or fumes, seasonal and diurnal variation of the cough. If exposure to dust and fumes aggravate cough in the patient, if there is the presence of a seasonal or diurnal variation, then it is suggestive of an allergic or atopic variant of asthma. Associated symptoms are also to be asked for. Ask about expectoration regarding the amount, color, character, and the smell. Also ask about fever, night sweats, weight loss, wheeze, heartburn, and hoarseness of voice. Fever, night sweats, and weight loss is suggestive of an underlying infection, tuberculosis, or malignancy. Presence of wheeze is suggestive of an obstructive airway disease. Presence of heartburn is suggestive of GERD, and hoarseness of voice is suggestive of a laryngeal origin of the cough. Now, expectoration. How to interpret the history findings of expectoration or in expectoration. You have to ask about the amount or color. If the sputum is blood stained or there is a hemoptysis, we consider it due to be an underlying infection, cancer, or bronchiectasis. A large amount, that is more than 20 ml, it is suggestive of an underlying bronchiectasis, cavitation or cancer yielding in the blood vessels, AV malformation, or a pulmonary vasculitis. If the sputum is white, it is usually physiological and is seen in rhinitis patients. Yellowish or green colored sputum is suggestive of an underlying infection. Pink frothy sputum is seen in pulmonary edema due to chronic congestive heart failure or CHF. Red-brown or rusty sputum is seen in infection and usually due to a pneumococcal pneumonia. Now, regarding the character, thick mucoid expectoration is suggestive of a COPD or bronchiectasis without any superadded infection. If the sputum is mucopurulent, it is due to an underlying infection. And if mucus plugs are present in an asthmatic patient, we consider it to be due to an allergic bronchopulmonary aspergillosis or ABP. Smell is also to be asked for. If there is a foul-smelling sputum, it is considered to be a purulent sputum and is suggestive of an underlying infection. Daily large volumes of yellow or green sputum is suggestive of an underlying bronchiectasis. Now, let us have some spots. This is a rusty sputum seen in pneumococcal pneumonia. This is a red currant jelly sputum which is seen in Klebsiella pneumonia. This is a black sputum which is seen in fungal infections. This is a pink frothy sputum which is seen in patients of acute pulmonary edema. This is a greenish sputum which is seen in staphylococcal pneumonia. And this is a sputum picture which shows the transition in the physical characteristics from mucoid, mucopurulent to purulent. Note that the viscosity, frothiness, and the greenish tinge of the sputum increases as it becomes more and more purulent. This is a figure of a sputum, pink frothy sputum which is seen in pulmonary edema, and this is a mucus plug seen in patient of ABPA. Now assessing case. Objective 1. Differentiating between the respiratory and the non-respiratory cause of chest pain. And second, establishing the exact cause behind the chest pain. So, given here is a table describing the different cardiovascular causes of chest pain and their characteristics. Anginal chest pain is an intermittent chest pain, episodic chest pain that lasts for 2 to 10 minutes. It is a retrosternal or a central chest pain which is constricting and heavy in nature. It may sometimes radiate towards the arms, neck, and the epigastrium and progressively increase in intensity over 1 to 2 minutes. It is triggered by emotion and exertion and also by cold windy climates and is relieved by rest and nitrates. It is associated with a breathlessness. Myocardial infarction. In myocardial infarction, it is an acute onset of a severe, constricting and heavy retrosternal chest pain. It often radiates to the arms, neck, jaw and sometimes to the epigastrium. It, unlike anginal chest pain, is not relieved by rest or nitrates and is very severe. It is associated with sweating, nausea, vomiting, breathlessness, and the feeling of impending doom in the patient, which is also called as anger anemia. Aortic dissection. Aortic dissection presents as a sudden onset, tearing or ripping chest pain in the interscapular retrosternal region. It is associated with sweating, syncope, focal neurological signs, signs of limb ischemia, and mesenteric ischemia. The pain radiates to the back in between the shoulders and is a very severe chest pain not relieved by any maneuvers. Now pericardial pain. Pericardial pain is usually retrosternal pain or can be a left-sided pain. It is gradual onset and present as a sharp stabbing pain. It can radiate towards the left shoulder or the back. It is the acute onset of the chest pain and sitting up or lying down can affect the intensity, especially it is relieved when sitting up and leaning forwards. NSAID can help in the pain and it is associated with a flu-like prodrome like fever, body ache, conjunctival congestion, breathlessness, etc. The most common cause of a pericarditis is viral but can also be seen in post-MI patients. Now esophageal pain. It is also a retrosternal or epigastric pain which develops gradually over 1 or 2 minutes. However, it can be sudden as in case of esophageal spasm. It appears as a tight pain or a burning pain and can radiate to the back and sometimes to the arms. It is intermittent, opening happening at the night time and is triggered by lying flat and by certain foods. Nitrates can sometimes relieve the pain if it is due to an underlying esophageal spasm. It is associated with heartburn and acid reflux. Esophageal chest pain can mimic an myocardial infarction. Now, the other cause of chest pain can also include a musculoskeletal chest pain. If a patient presents with musculoskeletal chest pain, it will be a diffuse migratory pain over the chest wall. Chest wall tenderness may be present, and in this case, you must take the history of a trauma to the chest wall. If the patient has a trauma to the chest wall and has breathlessness, in that case, you must do a chest X-ray in order to rule out an underlying risk fracture. This is a figure showing rash of herpes zoster shingles. In herpes zoster shingles over the chest, the patient presents with burning sensation over the chest radiating along a dermatome. Examination shows an itchy, reddish-colored rash along the dermatomal distribution as shown in the picture, and patient also has a very high-grade fever. Now, once we have established the chest pain to be due to a respiratory cause, how does the respiratory pattern of chest pain present? Let's have a look. Chest pain, if it occurs due to a respiratory cause, it is mainly a pleuritic chest pain. It arises due to irritation of the parietal pleura. The visceral pleura and the lung parenchyma are painless. It presents as a sharp stabbing pain in the lateral chest wall that worsens with deep inspiration and coughing, whereas the pain gets relieved with breath holding. Pleural effusion presents with a heaviness in the chest that is relieved by lying down on the affected side, a phenomenon which is called as strepopnea. Sorry, this phenomenon is not called strepopnea. Now, you have to establish the exact cause behind the underlying chest pain. So the exact cause of the chest pain is decided by the associated symptoms and the onset of the chest pain. A sudden onset chest pain is due to underlying pneumothorax if there is associated history of a COPD. However, it can also be due to pulmonary embolism if it is associated with a history of deep vein thrombosis (DVT) and other predisposing factors for embolization like immobilization. Gradual onset of chest pain is due to a pneumonia if it is associated with fever, cough, and sputum production. However, it can also be due to a malignancy or tuberculosis if it is associated with fever, night sweats, and weight loss. If the patient is an elderly patient that is more than 40 years, male, smoker, with hemoptysis, weight loss, night sweats, and clubbing, then you must suspect an underlying cancer. Any elderly male smoker with hemoptysis and weight loss must be assessed for underlying lung cancer, as such patients are at high risk of developing a lung cancer. Now, assessing Wheeze and Strider, what is the objective? To understand the probable underlying cause behind the wheeze and stridor. So wheeze is a music sound that is caused due to turbulent airflow via the small airways due to airway obstruction. It is an auscultatory finding and heard at expiration. Sometimes the patient may complain of a whistling sound during breathing and a chest tightness while breathing. Let us see an example of asthma. A normal airway is a wide airway. In a patient of asthma, the airway is narrowed down due to intramural inflammation. During an attack of asthma, due to inflammation, there is bronchospasm and the airway further narrows down, causing a turbulence of flow of air through the small airways like the bronchi, bronchioles, and this results in a musical sound that is heard at the expiratory phase. Presence of wheeze and stridor indicates an underlying obstructive airway disorder which includes asthma as well as COPD. Now, stridor is a harsh inspiratory sound which is caused due to turbulent airflow in the larger and proximal airways. It is caused due to severe obstruction at the level of nose, pharynx, larynx, and trachea. It is commonly seen in children due to a viral flu or a foreign body obstruction of the trachea. Now, the stridor can be inspiratory, can be expiratory, or can be biphasic depending on the site of obstruction, as shown in the picture. If the obstruction is at the pharynx and the supraglottic region of the larynx, then the stridor is an inspiratory stridor. If the obstruction is at the level of the thoracic trachea, then the stridor is an expiratory stridor. However, if the obstruction is at the glottic and subglottic region of larynx and cervical trachea, then the stridor is usually biphasic. Now, in patients who present with wheeze and stridor, you must ask about the onset, duration, and progression of the symptoms. Any seasonal diurnal variation if present? Seasonal and nocturnal aggravation of wheeze is suggestive of an asthma. If there is an early morning wheeze that is raised by sputum clearing, it is suggestive of a bronchiectasis. COPD, however, has no seasonal or diurnal variation of the symptoms. Aggravating and relieving factors need to be asked for. Is it associated with exercise? And associated symptoms like expectoration also need to be asked. If wheeze strain is associated with daily volumes of mucopurulent or blood-stained sputum, it is suggestive of bronchiectasis. Risk factors include allergy and smoking. If there is a history of allergic symptoms, that is, exacerbation of wheeze and stridor and exposure to dust, fumes, or on going out, or there is a seasonal variation of the symptoms, then it is suggestive of an underlying asthma. However, if the patient is a smoker, then it is suggestive of an underlying COPD. Now, the last part is to ask about the etiology-specific manifestations. It includes allergy to drugs and other substances like dust, smoke, food. It is suggestive of an asthma atopic asthma. In patients who present with ILD-like manifestations, that is a chronic cough, reps on auscultation. So occupational history becomes important in patients who present with ILD-like manifestations. In any patient who presents with a long-standing dry cough, low-grade fever, reps on auscultation, shortness of breath, you must suspect an underlying interstitial lung disease. Occupational history must be taken in these patients like plumber, shipbuilder or construction worker. Such people are predisposed to develop asbestosis. Stone crushers predisposed to develop silicosis. Coal miners commonly develop coal worker pneumoconiosis. Animal contact or farm laborer can develop hypersensitivity pneumonitis. Therefore, again we're stressing on the fact any patient who presents with a long-standing dry cough, shortness of breath, and crepitations, fine crepitations and auscultation is considered to be a case of an ILD, and in such patients, occupational history and exposure to animals must be taken as a very important history point. Smoking history is also very important. You need to quantify it in number of cigarettes per day or number of pack years. Smoking history is specifically important in patients to rule out a case of COPD or to consider a case of COPD. And it is also important in patients if you are suspecting an underlying lung malignancy. Sleeping habits are to be inquired. Ask for normal sleep habits and nighttime work. Ask, does the patient wake up exhausted after normal hours of sleep? Has the patient struggled to remain awake during the day? Also inquire about nighttime breathing disturbance from a bed partner. If these symptoms are present in a patient, that is, the patient wakes up exhausted after normal hours of sleep and struggles to remain awake during the day, then it is suggestive of an underlying obstructive sleep apnea. Also, history of contact with tuberculosis and family history of asthma must be inquired for. Now, in the last we described the MMRC dyspnea scale, which is used to grade the severity of dyspnea in COPD patients. Grade 0. Breathlessness only on strenuous exercise. Grade 1. Breathlessness when hurrying on level ground or walking up a slight hill. Grade 2. Where the patient walks slower than other people of the same age on the level ground due to shortness of breath, or they need to stop for breath when walking at their own pace. Grade number 3. Patient is short of breath after walking few minutes on the level or about 100 yards, that is 90 meters. Grade 4. Patient is too breathless to leave the house or breathless when dressing or undressing. This AMRC dyspnea scale is used to grade the severity of dyspnea in the COPD patients. Thank you.